Thomasine Beck, will you allow us to check your audio real quick? Can you hear us?
Yes, definitely. I can hear you fine, Angela. Good morning.
Good morning. If you'll mute back, so that we can go live shortly. We just wanted to make sure you could hear us.
Okay, thank you.
Good morning, everyone, and welcome to this year's Coming Together for the Cure. This is our 8th year, and we're excited to be coming into your homes. We know that this year is a different year because of the COVID virus and the pandemic, but however, we still wanted to be able to come into your homes, provide breast education. So we have a great program this year, and we're looking forward to you asking questions. You can always call in and ask your questions, but we are excited and we're going to get started this morning. We do have an agenda and we're going to follow our agenda closely. We're going to start out this morning with Mr. Ron Session, which is a practice operation manager with Blood Flowers Health Center. He's going to come in and he's going to do our welcome. And then we will move on with Cynthia Burrell, which is doing Who Am I? She's a breast cancer survivor, and she's going to give us her story and testimony. And then we will move on to Sharon Cox, which is our advanced practice dietitian at Blood Flowers. So we're going to move forward, and thank you so much in the help to fight breast cancer.
Well, good morning. As Vicki stated, my name is Ron Session, and I've been tasked with the job of actually opening up today's CTC conference. So what I want to do is just kind of talk about myself in a little bit in a sense of telling you what I am. And I want to do that by just kind of asking you guys to, number one, know what this term means, and the term is the word stimulus. Several years back, America was going through a hard time. The country had been given a diagnosis that it was sick. And the solution was to create what we call the stimulus plan. Now, what I want to do is give you an understanding of that word stimulus. And that word stimulus simply means to bring someone from where they were before you entered their life to where they are now that you have entered their life. And what we want you to do today is we want you to be the stimulus for someone. For me, my stimulus was my aunt and my cousin both being diagnosed with breast cancer, and me being 18 at the time and having to come to the understanding that that meant a change in their life. Now, we lost my aunt and her daughter also, both around the age of 39. So breast cancer, it's something that we have to deal with, guys, but we don't have to deal with it alone. And that's the task that I'm asking each of you to take on today, is to be the stimulus for someone who receives a diagnosis that they're sick. To be that thing, that person that comes into their lives at that most opportune time and help them work through this process. So again, as we go through this process today, what I want you to do is be someone's stimulus plan. Be that thing that moves them to where they were before you entered their life to where they are now that you have entered their life. So as we move forward today, I just want to say welcome, and we hope you guys have a great day. And by all means, please call in, send messages. We have a fantastic panel here today that's here to answer questions and to assist you. Again, I'm Ron Session, guys, and thank you for joining the CTC.
Thank you, Mr. Session. We appreciate that. And now we're going to move forward, and we're going to do a little moving around a little bit with our schedule. Instead of having Cynthia Burrell, we're going to ask Ms. Thomasine Beck if she would just come on, and we'll be able to and provide us with her information in reference to Who Am I? So welcome, Thomasine.
Good morning, Vicki and panel there. Thank you so much for having me on this morning. I just wanted to come and just encourage someone else. I am Thomasine Beck. I am celebrating 19 years surviving stage 1 breast cancer. I was diagnosed in 2001 and treated at UT Southwestern, which is a partner hospital there in the medical center. I got my chemo there. It was a whirlwind, just going through the process. If you're diagnosed and you've never been exposed to breast cancer or been around someone who's had it, it's all new, and all the terminology and everything can be quite overwhelming. But I can tell you that if you pay attention to your body, and this is sometimes difficult for women to do because we're such caregivers, we tend to ignore things. You have to pay attention to your body and understand that there are warning signs. And when those signs come, listen to it and then advocate for yourself. Go and get checked out. That's why we're coming together for the cure. We want to advocate for those women who aren't able to get breast exams, who aren't knowledgeable about what those warning signs are, and let them know that those things are available to them, that they can get screened. Early detection is the key to surviving this disease. I was stage 1. It was not estrogen fed, so they didn't really know what made it grow. So sometimes that happens. There were no history cases in my family either. I was the pioneer, so I was the only one out of 3 girls, and my mom and her sisters, nobody ever had breast cancer. So I was the first one and the only one, but that doesn't mean that you can't contracted that disease. So it's important to pay attention to your body, listen to it. Sometimes we're not just tired, there's something going on, and we do need to get an examination. So if you need help, Parkland is there with all that you need to connect you to get your mammograms done. So I'm here to say I'm a survivor. I walked this morning, got my 3 miles in support of breast cancer awareness. So I'm happy to be here. Thank you.
Great. Thank you so much, Thomasine. We really appreciate that. And we're looking forward to having more conversations with you in reference to your survivorship. So we commend you for being a 19-year breast cancer survivorship. We're going to move on now to Sharon Cox, and she's going to be providing us information on You Are What You Eat. Thank you so much, Ms. Cox.
You're welcome. Good morning, everyone, and thank you for tuning in for my presentation. Hopefully you'll get some ideas. It's about what to, go grocery shopping this weekend and what you can plan for your meals.
Read that, Sharon.
Okay. Upon joining, please mute yourself. All comments, questions should be typed in WebEx chat function. Enjoy. Okay, so again, the weekend is usually when we grocery shop, plan our menus for the week. And as you see, the plate has half is full of vegetables or plant-based foods. And these foods provide us with a lot of vitamins, minerals, fiber, antioxidants that can help reduce our risk for cancer. And then you have whole grains, which we all can add to our meal plan. And if we look at, compare the difference between these two people, one person is full of processed, pre-made food that increases their risk for illness, for cancer, for heart disease, for diabetes. And the other person that is consuming more plant-rich foods is less likely to end up with a lot of health problems. So again, try to include plenty of fruits and vegetables at each meal. Again, it reduces your risk for a lot of health problems, and that can also keep us in good health. And then we want to include plenty dark green vegetables like kale and collard greens, and also the berries also give us antioxidants and also help us now with the virus, help flood your body with vitamins and minerals and help improve your immune system. And then beta carotene comes from our orange colored foods. And that's what you do want to pick is different colored vegetables and fruits. But beta carotene has been shown by studies to reduce your risk for breast cancer. And then also foods and drinks that we want to avoid would be alcohol. We don't want a lot of added sugars from food or from drinks like sodas or sweet tea. And trans fat is too not very helpful. It also can lead to all types of health problems, eating too much red meat and eating processed meats. So your cold cuts, hot links, bologna, bacon, ham, those processed foods can lead to health problems. And then we do want to pick a variety of colorful vegetables for our meals. And if we can start early with our children, introducing them to cabbage, greens, broccoli, then it really does help reduce their risk for type 2 diabetes in children and obesity. And then these colorful fruits, again, you get your vitamins A, C, and E. You also get a lot of good fiber from these foods. And the antioxidants, again, reduces your risk or can really break down or prevent abnormal cells from forming. And then kind of like the red light, green light, you want to eat more of these nutrient-dense foods every day, not just for Sunday dinner, but every day you have half a plate of vegetables for lunch and dinner and snack on maybe some fruits for snacks, then that would help reduce your risk for health problems. And then the red light, these foods that are high in sodium, added sugars, and refined grains, which would be like your white flour foods, white breads, the hot dog bun, chips. These foods increases your risk for health problems. So we want to slow down or stop taking in so many of these foods. And then, of course, the portion size makes a difference. So if you are eating a lot of the processed foods, then remember to try to decrease the amount that you do eat, and that will help. And sugar, we all need to cut back on sugar from our drinks, like your coffee. That cup of coffee has 18 teaspoons of sugar, and on the average each day we may consume 42 teaspoons of sugar, which again causes inflammation and may increase your risk for cancer, diabetes, heart disease, and obesity. So you really want to try to cut back on the sweetness if you can, and learn find out what coffee might actually taste like without all the sugar and all the creams. We want to read out food labels and look especially for hydrogenated corn syrup, high fructose corn syrup, that's in can and bottled teas and sodas and juices. And there are other names for sugar too that we need to be aware of. But read your labels, read your ingredient list. If it's not, an ingredient that you recognize, then you probably do not want that food. And you don't have to give it up all at once, but just gradually start cutting back and start eating less of these pre-made foods. They are delicious and hard to give up, but just try to stick to your plan by including more vegetables and more fruits. So trans fat would be another ingredient you would want to look for on your labels. Trans fat may increase your risk for breast cancer. So research shows staying away from trans fats can help, reduce your risk for breast cancer. And if you don't know what trans fats are, look for the label, look for hydrogenated oils. So that, it may say 0 trans fat on the label, but if you look in the ingredient list and it has partially hydrogenated oil, then you're getting, those type of fats. Now, all fats are not bad, so we do want to include the omega-3 fats from salmon, sardines, avocados, from your nuts and seeds, and extra virgin olive oil. These foods, again, are good for your heart, good for your brain, and also may reduce your risk for cancer. So again, what we eat will make a difference in our health. So you want to enjoy the foods that you eat. You want to plan your meals as much as you can ahead of time so that you don't rush in and end up eating a lot of refined or a lot of processed foods. So you have the power, the choice is yours. So think about how your plate looks and enjoy your food, okay? And a few messages to take home. Again, eat more food that grows on the ground, more plant-based food. Be mindful of what and how much you eat at a meal or for the day. And also, you are what you eat. Thank you.
Oh, great. Thank you so much, Sharon. That was great information, and I hope that you all, the audience, I hope that you all are really getting some valuable information. Right now, we're going to go ahead on. We have some questions that's coming in. So, Sharon, do you mind if I ask you a couple of questions?
No, go ahead.
Great. Okay, we have this one question from the listener. It says, what are some healthy on-the-go snacks that are good for traveling?
Okay. So, of course, fruits will be your number one choice. You can always have apples, pears, fruits that don't need refrigerated. But anything from a handful of unsalted nuts, your almonds or walnuts would be great, great snacks. Yogurt, if you have an insulated bag to keep it in. And you could do your own peanut butter crackers with unsalted crackers or wheat crackers. Or string cheese would be, on-the-go snacks.
Okay, great. Okay. Also, another question from a caller. It says, what are some sodium-free, low-sodium options for seasoning your food?
And of course, Miss Dash would be number one. And then anything that ends in powder. So onion powder, garlic powder, not the salts. If you like fresh herbs or dried spices would be great. And then there is a product on in the stores called Herb Ox. It is sodium free. It comes in chicken, beef flavors, and you can boil your cabbage, your broccoli in it, and it gives you, it gives you a little salty taste, but it is salt free.
Great. Also, thank you for that, Sharon. We have another question from a caller. It says, are frozen vegan meat alternative to healthy lifestyle?
They can be, but because it is a processed food, that means it has more sodium, so you do need to limit. I eat those, but it may be 2 or 3 times a week that I may eat one of those products because they are processed and again have extra sodium. But they are, they do provide you with some good nutrients, protein, and some fiber, but it's not a food that you would want to eat every day.
Okay, great. Okay, well, thank you so much. Do we have any more, we have any more questions? Okay, so no, that's all of the questions that we have. We do thank you for your excellent presentation, and we're gonna move on, and right now we're gonna move on to Tracy. She's a 3-year breast cancer survivor. She's gonna be speaking on Who Am I? And after Tracy, we will have Dr. Jody Hayes, who is an assistant professor at the Breast Center, and she's with UT Southwestern Oncology Department. Welcome, Tracy. Thank you so much for being a part. We really appreciate you doing this for us. So can you share with us your story?
Yes, thank you, Vicki, for having me, and I'm excited to talk to the group here today. My name is Tracy Tyner, and I'm a nurse practitioner here at Parkland Hospital, and I was asked to share my breast cancer story with you. My story started when my mom was diagnosed with stage 3 breast cancer at the age of 47. Sadly, she passed 5 years after that. It's been probably about 22 years since she passed. And because of my family history, I started my annual mammograms at the age of 35. Although mammograms can be very uncomfortable and very anxiety producing, I knew that they were important for early detection. And over the years, I've had lots of mammograms, lots of ultrasounds, MRIs, and biopsies for suspicious areas, all of which at the time had been negative. And now I'm going to fast forward about 20 years. And in March of 2017, my younger sister was diagnosed with stage 3 breast cancer. And she was 35 years old at the time. After hearing this news, the nurse in me went into overdrive, learning everything I could about breast cancer, treatment options, to make sure that my sister got the best care possible. She lovingly called me her drill sergeant. I don't know if that was a compliment, but I think she was appreciative. She's appreciative now. Fortunately, we had a wonderful sister-in-law that provided the much needed comic relief during this time period. So the 3 of us made quite the team. I am excited to say that my sister did beat her breast cancer. Her response to chemotherapy was amazing, and she just celebrated 3 years with no evidence of disease. So during my sister's treatments, her oncologist told me that because both my mom and my sister had breast cancer, that I fell into a high-risk category. So they recommended that I get genetic testing and start alternating MRIs and mammograms. My sister was down in the Houston area, so she was at MD Anderson, and I'm in this area. So I met with my surgical oncologist at UT Southwestern for my routine mammogram that was in, I think it was like March or April of 2017, and told her what was going on with my sister. So I had my mammogram, and it was normal. It was hard to read because I have very dense breasts, which is the story of my life. And those of you that are getting mammograms have probably heard this as well. My genetic test was negative. I was scheduled for a breast MRI in November of 2017. So in the meantime, my surgeon and I discussed the options of, whether or not I wanted to do a prophylactic bilateral mastectomy because of my family history. But I had plenty of time to decide. My sister was going through treatment, so there was no rush. So I spent the rest of the year thinking about that and helping care for my sister. Then November rolled around and my MRI showed a suspicious area. All of us thought that it was probably just scar tissue from an old surgical biopsy site. But to be sure, we decided to do an MRI guided biopsy. So I had that done. And then I got the phone call on December 27th, right after Christmas in 2017, that I was diagnosed with DCIS, which is ductal carcinoma in situ. It's a very early stage breast cancer that's localized to the milk ducts, which means that it had not spread out into the surrounding breast tissue. Because it was an early stage breast cancer, I was grateful that I would not have to do chemotherapy. My options for treating this were to the watch and wait approach, because there have been reported cases that have shown that DCIS may never progress in some women, so that is an option. Lumpectomy, where they take out the tumor and the tissue around it. I could do a single mastectomy, which they would remove the whole breast on the side with the tumor. I could do a double mastectomy where they would remove both breasts, which I had kind of been contemplating that before my sister was diagnosed, but now I had to make the decision. So if I did a lumpectomy, then they recommended radiation therapy. And if I kept any of the breast tissue, that they recommended tamoxifen, which was a pill that helps block estrogen production because estrogens can drive breast cancers. And if I chose a mastectomy, then I would also have to decide whether or not I wanted to do breast reconstruction. So my doctor and I talked about my risks for developing another breast cancer or the DCIS becoming invasive if I wanted to do the watch and wait approach to help me decide what I wanted to do. And we also talked about risk scores. So for the average population, a woman's risk for developing breast cancer is about 12% over her lifetime, which is about 1 in 8 women. My risk score, when I knew only my mom had breast cancer, in addition to my other risk factors that they used to calculate into that, came out to a 25% lifetime risk of developing breast cancer. So that's about 1 in 4 chance of getting it over my lifetime. Then when my sister was diagnosed, I had 2 immediate family members that had breast cancer. So my risk shot up to 39% lifetime risk. So to me, that's close enough to a 50-50 chance. So those odds were way too high for me to decide to just watch it. I knew that I didn't want radiation therapy and I didn't want to take a pill, the tamoxifen, and because there's risk with both of those treatments. So I knew immediately that a bilateral mastectomy was the way I wanted to go. Plus, I didn't want to spend my life wondering if I was going to get breast cancer again, and this could definitely lower my risk. I've seen this disease up close. Treatments are so much more improved from when my mom had it. My sister was amazing through it, responded very well, but it's still a hard road. And I just wasn't interested in going down that path personally. And I mean, I guess the perk of having the bilateral mastectomies is that I wouldn't have to get any more mammograms. So that was kind of a bonus. I would say the hardest decision for me is whether or not to do breast reconstruction. So I made sure I had all the facts before making the decision. What are the risks of the implants versus the flap reconstruction? How many surgeries are we talking about? How long would I be out of work? What are the short and long-term complications of reconstruction or not having reconstruction? What would it be like to live without breasts, which is known as going flat or has recently been defined as aesthetic flat closure. Most of my answers came from my surgical oncologist. I did meet with a plastic surgeon just to make sure I had all the information about my reconstructive options, benefits and risks. And then I did reach out to support groups on the internet to see what life would be like to live flat. I chose to go flat and not have reconstruction. I knew immediately that I didn't want implant reconstruction. I wasn't interested in having a foreign object in my body. Plus, implants may need to be replaced every 10 to 20 years. And so I wasn't interested in having a surgery later in life because that could be in my 60s and 70s. And having surgery at that age is a risk in and of itself. My other option was a deep flap, which I seriously considered. They take many women have this procedure. It's where they take tissue from your tummy and then they make a breast out of it. So I thought long and hard about that. And then I decided that, and this is a common phrase that I hear, is that I didn't want to rob Peter to pay Paul. So I would have to have a big abdominal incision in order to make a breast. The risks for breast reconstruction, to me, are not small. Some of these cases can last 12, 14 hours under anesthesia. There can be, there's a big abdominal incision, wound management issues, longer hospitalization. And if you have a flap done, you always worry about whether or not the flap will survive and, what the reconstruction will look like. So flat breast reconstruction can take multiple surgeries to get the right breast shape. Plus, that would mean more time off work for me, and not to mention, the out-of-pocket deductibles for multiple surgeries, especially if you can't get all your surgeries done in the same insurance year. So that's something to think about. And all this, I was trying to help take care of my sister in the middle of her treatment. And so after weighing all the pros and cons, I opted out of reconstruction and told my surgeon, just make me flat. Now, that being said, lots of people get implant and flap reconstructions and do just fine, have no issues, or if they do have some complications, they're minimal. The decision is very personal. There's no wrong answer. You just need to make sure that you have all the facts to make an educated decision based on what is right for you and what your circumstances are. So in January 2018, I underwent a bilateral mastectomy with flap closure. My surgeon was very supportive of my choice, even though my choice doesn't really match the general societal expectations that women should have breasts, and that most people assume that if you have breast cancer and you have a mastectomy, that you'll opt for reconstruction. I will admit it wasn't easy at first, but it has been a very liberating experience for me. It is very different to not have breasts, and I definitely have to put more thought into the clothes that I wear and how they fit on me. But I think overall, I'm very happy with my choice. If I do need boobs to fill out an outfit that I want to wear, I have prostheses, so I can use those and no one ever knows the difference. I was very self-conscious the first year, and I still find myself at times being a little self-conscious, wondering if people are staring at me, wondering why I don't have breasts. But I think I've since discovered that no one really notices. And if they did, I don't really care because I'm happy with me. The most important part of my journey was that I was able to get back to work early, and I was able to be there for my sister to get her through her cancer treatments. And my decision has allowed my risk to go from 39% down to less than 1% chance of developing another cancer over my lifetime. And I'm very good with that number. So to sum it up, my sister and I are both doing very well. And I encourage everyone out there to talk about breast cancer, especially if you have a family member with breast cancer. Do your self-breast exams, and please, please get your mammograms. Thank you for allowing me to share my experience.
Thank you so much, Tracy. Thank you, thank you, thank you. We really appreciate you sharing your story, and we encourage you to continue to be a part of the Coming Together for the Cure, and we look forward to hearing from you again. As we move forward, we're going to go to Dr. Jody Hayes, and she's going to be able to provide us with a breast cancer myth. Dr. Hayes, are you ready?
I am ready. Are you able to hear me okay?
Yes, we can hear you. And again, thank you so much. We know that we've been double dipping with you, but we really appreciate you being a part of the Coming Together for the Cure. We couldn't do it without you. So again, thank you, thank you, thank you. So right now,
You're very welcome. You're very welcome. And I really want to thank the Coming Together for the Cure organization for not only allowing me to speak and inviting me to speak, but also for caring so much about getting these messages out to the communities and out to anyone who is listening. It is very important that we keep these conversations going and that everybody is just armed with as much information as possible. So my name is Jody Hayes. I am one of the breast imaging physicians at the Parkland Breast Center. We're the physicians that read your mammograms. We do the diagnostic mammograms. We do the breast biopsies. And if you are diagnosed with cancer or with a high-risk lesion, we help navigate you into the system. So we're the gatekeepers for a lot of the stuff that goes on at Parkland for breast health. So I want to acknowledge my 8 fantastic colleagues. We are a very cohesive, great group, and we are just so excited to take care of anyone who comes our way. What I wanted to talk to y'all about today is some common breast cancer myths that we hear from our patients and when we're out in the community, so that we can discuss a lot of truths and get some more information. Next slide, please. Oh, can we go back a little? Sorry. Hold on 1 second. They're going the wrong way. If you'll back up the slides the opposite direction. Perfect. So one of the most common myths that we hear quite a lot is that only women with a family history will get breast cancer. I often have my patients tell me, oh, I knew it was nothing, and I don't have any history in my family, so I won't get breast cancer. Next slide. The important fact, and this is probably one of the most important facts I'm going to tell y'all today, 70% of patients that are diagnosed with breast cancer have no risk factors. So risk factors include genetic mutations, reproductive history, that's how much hormones you're exposed to, whether or not you took hormones, having dense breast, having a family history, having a personal history of breast cancer or of high-risk lesions, having radiation therapy to your chest, and the most important risk factor that we overlook quite a bit is aging. So, and we'll get to aging in just a little bit, but if you do have a family history of breast cancer, first-degree relatives are defined as the parent, the sibling, or the child. One of those affected doubles your risk. If you have 2 of those affected, that increases your risk 5 times. And the more first degrees that are affected just increases exponentially, similar to how Tracy was discussing with us. If you have no first degree relatives, but second degree relatives affected, that's our cousins, aunts, grandparents, your risk does increase, but only slightly. However, if you do have multiple generations on one side of the family, then that increases the probability that you have a breast cancer gene. At Parkland, we have a very good genetics program, and we try to plug anyone in that we have any suspicion there may be a breast cancer gene in the family so that we can get their risk factors adequately assessed. But again, remember that 70% of breast cancer patients have no risk factors. Next slide. One other myth is that young women don't get breast cancer. Next slide. As I mentioned, age, increasing age is a risk for developing breast cancer alone. So the 1 in 8 stat that you hear a lot, that 1 in 8 women will get breast cancer, you actually reach that statistic when you get older, when you get into the 60, 70-year-old age range. So that's why it's important to continue doing screening mammograms as you get older. 55 years and older, those women will diagnose about 7 out of our 10 cases of breast cancer. However, 5% of breast cancer is diagnosed in women below the age of 40. The population that we want to screen for most women starts at the age of 40. Since we're starting at 40 and we're typically not doing breast screening in younger women, what we recommend now is that at the age of 25, have a discussion with your family physician. He will sit down or she will sit down and discuss risk factors with you, family history with you, see if there is any concern that you might have elevated risk factors, family history. They will teach you how to do breast exams. There's lots of information. If you come to us, we will teach you how to do breast exams. But at that age, we want you to start doing breast exams, have that discussion with your risk factors. See if you do qualify for early screening. And if you don't, at least keep doing your breast exams and then start coming to us at the age of 40. Next slide. Another myth is that men don't get breast cancer. Next slide. The fact is 1% of breast cancers do occur in men. 2019, 2,670 men were diagnosed with breast cancer. That was up about 400 men from my presentation that I put together originally in 2016. That's when we updated the stats. 500 men died last year in 2019 from breast cancer, up from about 410 in 2016. So men do carry a higher mortality rate than women. There's less awareness of male breast cancer. It's also a population that we typically don't screen. Because of those two things, there is often a delay in treatment. So oftentimes a man that has the same cancer will do slightly worse. Another myth is that women can't get breast cancer if they're pregnant. Next slide. Sadly, this isn't true. Breast cancer is the most common cancer that we diagnose in pregnant women. We also diagnose breast cancer more often in women in the early postpartum period, so new mothers. It's a very devastating diagnosis to get at this time of your life. This is a very confusing time for women because their breasts are changing. They're trying to get used to how breasts feel when they're starting to get ready for lactation. We would much rather see you in our clinics for nothing than to miss the chance to find an early breast cancer. So if you have something you're concerned about, please make sure you let your physician know, and we're always happy to get you in the clinic and put that fear to rest. A myth that we do hear commonly also is breast cancer always forms a lump. Next slide. The truth is not all breast cancers will present as lumps. There are about 8 symptoms and signs that we teach people to look for. One of them is a breast lump. You'll notice that's in the bottom right corner of the screen. And that's because the majority of lumps that we actually find in patients are normal. They're just normal things or they're benign masses. However, a lump can definitely be a sign of breast cancer. You can also develop a lump only in your armpit, and that can still be a sign of breast cancer. Other things we want you to look for are changes with the nipple, such as the nipple pulling back or inverting. We want you to watch for clear or bloody nipple discharge that comes out all on its own, especially if it's only on one side. We also want you to watch for skin changes, the skin to get thickened in an area or red or a rash. The skin may dimple like an orange, or it may pull in, or there may just be a one-sided or a one area thickening. Any of those things can actually be a sign of breast cancer and something that we need to check out. Next slide. Myth, wearing an underwire bra can cause cancer. Next slide. There has been no scientific proof that bras of any kind, with underwire or without, can cause cancer. One of the things that I have not talked about yet is pain. Breast pain is extremely common. In any given day, 50 to 75% of the women that we see in our clinic come in complaining of breast pain. 99% of breast pain has absolutely nothing to do with cancer. It's simply the fact that you're a woman, you have hormones, your breasts react to those hormones, and you have breasts on the front of your body that don't have much support, so they pull on the ligaments. A bra that is well fitted can actually help with breast pain and help support the breast. So we actually do advocate the use of wearing or the use of bras. We do want you to think about bras that fit well. If you're having pain, maybe try changing your bras. Again, it's not typically a symptom of breast cancer, but we're always happy to see you in the clinic for that too. Next slide. And this has been a new one over the years, that putting a cell phone in your bra can cause breast cancer. Next slide. Putting a cell phone in your bra has no scientific proof that you will get breast cancer. We do have women that do put all sorts of things in their bra, their cell phone, their keys. I have not seen candy bars in the bra, but I'm sure it happens. Things in your bra so far will not cause cancer. They can cause trauma. They can cause pain. So it might not be the best place to store something, but don't worry about the cell phone actually causing cancer. Next slide. This we hear a lot, that deodorant or antiperspirants can cause cancer. Next slide. There has been no scientific proof, and there's been a lot of research on all sorts of chemicals and breast cancer, including chemicals that are found in deodorant and antiperspirants, as well as chemicals that we take commonly, coffee, caffeine, things like that. So we have found no link at all between deodorant, antiperspirants, and breast cancer. We do ask you to either take your deodorant or antiperspirant off or not wear it to the breast center, simply because we can actually see it on the mammograms. And the way it looks on the mammograms sometimes can look like the early form of breast cancer that Tracy was talking about, the DCIS, that they appear as little tiny pieces of salt. And that is exactly how deodorant and antiperspirant look. So we will clean you off if you haven't taken it off. And that's the only reason we say don't wear it to the breast center. Otherwise, if you want to wear it, go right ahead. There's no harm. Next slide. Myth, women of color are more likely to get breast cancer. Next slide. This is from the SEER data. The SEER data collected information on tons of patients across the entire United States. And what we found when the SEER data came out is that white women actually have the highest incidence of breast cancer. However, mortality rate, which is the death rate, is highest among African American women. The lowest death rate is in our Asian Pacific Islander population. Lowest actual incidence rate, diagnosis rate, is in the American Indian Alaska Native population. But this is part of why Coming Together for the Cure make sure we get our message out to certain areas. We have identified in the Parkland system the zip code that the majority of cancer deaths and the worst diagnoses are coming from. And it is a zip code that has a large African American population. And so that is the zip code that we try to target the most to get the information out there. There are a lot of factors on why this is happening. A lot of it is decreased access to care. So we're trying our hardest to get out in that community. Decreased information, which again is why we're bringing programs like this out. And also there's a lot of fear. There's a lot of misinformation. So we're trying to get the message spread as best we can. As you were probably noticing when you listen to some of the survivors speak, it is very overwhelming when you get this diagnosis. It is very hard to take all the information and organize it and decide how you want to handle this. But that is why we have got these teams built. We've got a great network and system built up so that we can help guide you through when you get this horrible, devastating diagnosis, so we can get you through the other end. And so we can also take care of your family members, your daughters, your sisters, your mothers, anyone else that may be affected by this diagnosis. Next slide. A myth that we do hear is nothing can change my risk of breast cancer. Next slide. The fact is that there are certain things you can't control, like aging, like your family history, the exposure to your own natural hormones, but there are still several things that you actually can control to lower your own risk. Research has shown that in patients with higher physical activity levels, they have 10 to 20% lower rates of diagnosis of breast cancer. Some of that is decreasing the fat content. You've heard a few of us talking now about hormones. Estrogen, which our bodies make, is stored in the fat and it's converted in the fat. And if you have an estrogen receptor type breast cancer, then that can make a big difference in that cancer diagnosis and in that cancer treatment. So keeping your body fat down, getting physical activity, decreasing alcohol and certain things in your diet. One thing that is not talked about a lot is breastfeeding. if you are young, if your daughters are young, if you're still at that age, if they are wanting to breastfeed, breastfeeding is protective for breast cancer. Every year that you breastfeed, you decrease your risk of breast cancer by 4%. And that is cumulative over your lifetime for every year that you breastfeed. So if that is something that you're open to, your daughters are open to, it is great for the child, and it is actually great to protect you from breast cancer. Next slide. And that's the end of my talk. So please remember, get your screening mammograms, encourage your friends, your family to get your screening mammograms. We are all there to guide you through the process, both at the CTC, through the clinics, and at the breast center.
Great. Thank you so much, Dr. Hayes. Thank you, thank you, thank you. We have a couple of questions that we have from some callers.
Okay.
One of the questions is that, does taking multiple vitamins daily prevent breast cancer?
Sadly, no. As of right now, pretty much one of the only protective factors that you can do was the breastfeeding. Vitamins, we have not shown that there's any change. Vitamin E can help with breast pain, but that's the only vitamin that we have seen that has actually helped as far as prevention. Now, again, as we were talking earlier, your diet does help to decrease your risk. So healthy diet is important, lowering your fat content is important, but as far as preventing cancer, we have not found a vitamin for that.
Okay, thank you for that. Another question from a caller is, breast cancer is genetic, so there is nothing I can do to prevent it?
I'm sorry, could you repeat the first part?
It says, since breast cancer is genetic, is there anything I can do to prevent it?
Well, like we were saying earlier, breast cancer is actually not really genetic. 70% of people will be diagnosed with breast cancer that have absolutely no risk factors at all. So while genetic information is important, it has nothing to do with every single breast cancer, or it doesn't have things to do with every single breast cancer that we are diagnosing. So it's important to know your genetics. It's important to know your family history, but you are still at risk if you are a woman and you have your breast.
Okay, thank you for that. Another one is that I'm a breast cancer survivor. My daughter is 20. Why can't she get a breast exam and get a mammogram?
Well, if you're a breast cancer survivor, now that some of the health insurance laws and regulations, if you will, have changed, it is important for your daughter to have that conversation with her doctor. If you were genetically screened and you were positive, she can be genetically screened. If you were not genetically screened, she actually still may qualify for genetic screening. One of the things that the geneticists tell us to make sure people know is that certain insurances handle genetic screening differently. So if you don't qualify for genetic screening, your daughter might. If she doesn't, her sister might. So it's important that all the women in that family talk to their physicians, because some of their insurance may actually prove it. And once we can get a genetic diagnosis in one individual, that usually will allow us to test the whole group. So that is one thing to be aware of. But have her talk to her doctor about risk factors. Like we said earlier, that increases her risk factor right there 2 times, especially if mom was diagnosed with a premenopausal breast cancer. If mom was diagnosed premenopausal, so we want to know mom's age, we want daughter to start screening mammograms 10 years before. However, we don't recommend screening mammograms below the age of 25. And that there's several factors to that. One of them, the breast density and the radiation exposure. So if she's below 25, if she's at 20, then the conversation needs to be more physical exam, possible MRI, getting her plugged in with genetics.
Okay, great. Thank you for that. We have one more from a caller. You had said about men having breast cancer. Can you let me know or say the date that they should start getting breast screenings?
Well, men typically, they're 1% of the breast cancer that's diagnosed. Men don't typically have ductal units, which the majority of women's breast cancer is diagnosed is in the ductal units. They also they have a little bit of ductal units, they have no lobular units. So the other form of breast cancer, lobular breast cancer, is not diagnosed in men at all unless there's a genetic malformation. And so with men, the men that we want to put into a screening program, this is very important because a lot of men don't know this. If you have a family history of breast cancer, if your family is carrying that genetic risk, if your mother, sister, daughter was diagnosed with breast cancer, or dad or son was diagnosed with breast cancer, those men do need to have a discussion with their physician, and we need to either do physical examinations or consider screening. The other group of men we want to screen is any man that is going through gender reassignment and taking female hormones. Those men we do treat the exact same as a woman. If they're going through hormone therapy for gender reassignment, at that point, we screen them exactly like we would a woman.
Well, great. Are there any other questions that we have? Okay, no. Well, thank you so much, Dr. Hayes. We really appreciate this. This has been such valuable information, and thank you. And we will look forward to having you present again on next year.
Thank you very much for having me.
Thank you. And we're going to move on, and we're going to come to another segment in our symposium, which is Who Am I? And we have Cynthia Burrell, which is a 3-year breast cancer survivor. She will be speaking, and shortly after that, we will have Dr. Merlin Allaku, which is a professor, and she will be giving us information on Who Am I? I am my sister's keeper. Thank you, Cynthia. So we're looking forward to hearing from you. Can you share your story with us?
Yes, good morning. Can you hear me?
Yes, we can.
Okay. Sorry for the technical difficulties there this morning. Well, my name is Cynthia Burrell. I was diagnosed with breast cancer at the age of 44. And my journey started August 12th, 2017, when God told me to check my breasts. I was lying in bed and I heard a voice say, check your breasts. So I knew it couldn't be anybody else but him. So that night I checked my breast and I found a lump on my left upper quadrant of my left breast. That Monday I called the doctors to let them know, because I had already had a mammogram scheduled, and I had a mammogram a year before and it was fine. So I had a mammogram scheduled for the same month of August, but I had to get it moved up because of I found the lump. So my journey, in the beginning, I was okay. I think it started once I started having the surgeries. But in my journey, I'm the first person in my family to have breast cancer. I did a genetic test, and no one else in my family on either side, my father nor my mother's side, had breast cancer. So I just call myself the chosen one. I went through through all my MRIs and everything, and then they found something on my right side, on my breast. So I decided to take both breasts. On November the 2nd of 2017, I did a double mastectomy. So the surgery was long, but I decided to take both breasts. I prayed about it and I talked with God, and we decided to just take both. Starting December the 15th, I started my first round of chemo. I had 3 options in which I decided to just do both, take both breasts. My first option was just do a lumpectomy and do radiation and chemo. My second option was just to take one breast and do radiation and chemo. And my third option was just to take both breasts and just do chemo. I didn't want to do radiation because the radiation process was long, and also the radiation process is harsh for your body. And I didn't want to have to deal with that discoloration, the burns and stuff like that. So I just went ahead to take both. I finished my chemo in March 23rd, 2018. I had 8 rounds of chemo. So I waited a year. I talked to the one of the plastic surgeons, and I decided to do the D-flap, which I did a fat transfer from my abdomen and to my breast. The reason why I did that, I said, because since my body has been treated from the chemo, I can use my own body since it's been treated. And then I had a second option to do breast implants. So the reason why I chose the first option is because, like I said, my body's been treated. It has been treated from the chemo with the chemo. And also, if it got rejected, I still have a flat stomach in the process, but I can also use, have the breast implants. But I had options. I just did like part A and part B to what I wanted to do. And I did a lot of research, and that's the reason why I chose the double mastectomy. I'm also a veteran. The VA paid for my my surgery. I use UT. They sent me to UT Southwestern since they don't have women's health. And I also have my own insurance too, so I didn't have anything coming out of pocket, which was a blessing. In 2019, I had my first reconstruction surgery. And that surgery took, I think, 12 hours. And then this year, I had another two reconstruction surgeries. So I'm finished. I said I'm not having any more surgeries. If it's not together now, I'm not going to do it again. But I chose to continue with the reconstruction surgery because I felt that something wasn't sitting right with me, and the doctor said the same thing. So with that said, you have to have your own options. You have to do your own research and decide what you want to do. And continue to stay positive in your process. I did go through a lot of depression because it is hard, especially when you're by yourself. You live by yourself, and you don't have anybody there that's been through the process of what you're going to, and you're actually looking at yourself in the mirror, looking like, okay, God, is this the journey that you wanted me to take? So, but now I don't question him anymore. I just talk to women. I talk to young women. I talk to my patients about the process and let them know, hey, you need to get your breast checked. Okay, you need to do this. And every time, like on Wednesdays, when the women come to where I work, I compliment them and I say, thank you for getting your breast checked. I really appreciate it. I said, because a lot of us don't want to do it, but I'm glad you're here. So I try to, I know I'm here on this journey to help others through this process. And I've had a lot of friends that have had breast cancer and they're gone. They passed away. And my breast cancer was a rapid breast cancer. It was a rapid growing breast cancer. And the medicine that I was on for my rheumatology medicine stopped the growth of my breast cancer, stopped the growth of the tumor. So that's why I know God has me here for a reason. And if he didn't, I would be gone right about now. I do have my days where I feel sad because somebody else has passed away from what I've had, but I'm here for a reason. I'm here for the CTC to help our community to beat breast cancer, fight breast cancer, talk about breast cancer, because it's a disease, but it's not a contagious disease. It's something that we can help our people, whatever color you are. I mean, whatever race you are, men, women, we just need to come together and talk about breast cancer, because it wasn't talked about when I was growing up. It was like a secret. And my journey here is to talk about it, be about it, walk it, and let everybody know, hey, you're going to be okay because God has your back. But my journey, my mom, the other thing, my mom was my nurse. And it was tough. But my process of my healing was amazing. I didn't have breast pain. I didn't have pains from the surgeries. So that's why I say I'm here for a reason. I didn't have any pain, any discomfort. The only thing I had with the chemo is that my nails turned black, my toenails turned black, my tongue turned black, and I had to change my silverware. But other than that, I didn't have any complications. And some people tend to have those complications, but I didn't have any of those. My mom had my breast pain, so that's kind of weird to me. But I'm just here to, if anybody needs to talk to me, I'm here to give my input of my journey of how you should research things before you just choose what you want to do. And just continue to have faithful friends around, happy family around, and it'll keep you lifted. And that's it.
Much for that inspiration, Cynthia, and thank you, Cynthia, so much for those inspirational words. We really appreciate you being a part of the CTC, and we ask that you continue to help us in support in the fight to eradicate breast cancer. We're moving on now to Dr. Merlin Allaku. How are you, Dr. Allaku? Can you hear me?
I'm doing very fine. I have some slides. Oh, you guys have them. Oh, perfect.
Yes, I do. I do have your slides, but before we get started with you, want to tell us a little bit about yourself and about your research that you're doing with the women in the community?
Oh, absolutely. So I'm at the School of Public Health at UT, and I'm in the Department of Health Behavior there. So my research mostly focuses on healthy survivorship, thinking about how we can help those who have completed treatment to live healthier lives. So thinking about physical activity, nutrition, behaviors, continued surveillance for their cancers. And also trying to extend that to think about how we can involve caregivers. So the work I've done has been in churches, in other community spaces, looking at different modalities. We use we've done some smartphone work using message apps to help women. We've had peer-to-peer support. We had online interventions towards that end. So I'm very excited actually to be here to talk a little bit about support and being our sisters keepers in this journey. So I can get started. So I guess I don't control the slide, so.
No, I have it.
Okay, next slide. Thank you. You can, I think you have to click again, yes. So obviously cancer is hard, and we've heard that. I know Cynthia just spoke in letting us know a little bit about her journey. And so this is a big understatement that cancer is hard. In the journey of survivorship, and you can click again, when we think about what constitutes survivorship, there's mainly two pieces. There's a medical component where from your medical team in treating the cancer. And then there's also this bigger need of psychosocial support, which has to do with things like mental health, education around what to do and how to survive, the spiritual component, keeping your financial health, and getting group and social support. So what I want to do is to talk a little bit more about those needs. So first of all, what we know from the literature and from the data, that when people are not supported, and and we heard anecdotally, obviously from Cynthia, who just said it was hard, right? We think about emotional distress and depression is a big part of that when there's little or no support. High anxiety and stress, loneliness, stigma for the disease, and certainly reduced access to services, because if you're not being supported, often people don't help. But what we do know is when we, in terms of benefits, when we are supported, you can click the next thing that we know, continue, is that people have better outcomes or health outcomes when we get the support we need. The second thing is your improved quality of life. And then finally, which also helps extend the quality of your survival. So if I were to ask folks in the room or any survivor, anybody for that reason, to raise their hand if you've ever gotten advice or support that you didn't need, I'm sure everyone would raise their hands, right? So sometimes the support we get isn't often matched with what we need. So let's talk about what those areas of support are for survivors. Oftentimes it's peer-to-peer support that is needed. Cynthia talked very eloquently about her helping other women. So certainly in the form of support groups, and this could be online or in person. The second area of support is thinking about in your workplace, what is needed in your workplace? Who can you share that information with? And where can you get support? Know your rights around insurance needs, work time, how long you can take off. When is it okay to return to work, which is a conversation you may have to have with your physician. Balancing both your work and survivorship in your treatment. Oftentimes people like to go right back to work, or they pretend they're, and we've heard from many survivors who've told us, I was working all the way through my treatment and trying to keep that a secret. And think about all that stress, the added stress that's there. The other area of support is in terms of your healthcare team. Having to establish really good communication, so that even if you need to have and to consider a second opinion, you're able to do so. And thinking about talking to your support team, your healthcare team, of all the follow-up care that's needed and all of the communication around that. The last area is really in terms of friends and family, establishing and creating good communication so they're understanding your needs and asking for help. Not only asking for help, accepting the help when it's given. So that's also important. So let's talk about specific kinds of support. So there are 4 kinds of support that can be given or received. So that's emotional, informational, tangible, and a sense of belonging. And I'll talk about each one of those quickly. So the first one is emotional support. So we know what, most of us know what that means. It's expressions of comfort and care, making someone feel better, and just by listening, right? You know, Cynthia mentioned when women come in, she says, I really appreciate you coming in for getting your breast checked. That's a form of emotional support right there. Okay, the second one is belonging, thinking about the kinds of shared social activities that bring women a sense of belonging, the things that you've done before your cancer, you know, whether it's your book club or your exercise activities of people that you've done things with, and having the friends just simply hang out with you, right? Thinking about tangible support. That is actually the material support. Things like who can maybe help pay for something that you need, taking you to the doctor. Maybe it's, you know, cutting your grass, doing some household chores that actually helps you. The other thing is informational support. Who can provide advice and guidance? And sometimes that's another cancer survivor. Sometimes we look to our family members to do all of these things, and that is not oftentimes possible. So thinking about each of those areas and who might be able to help you with that. So we know that survivors do need support. And here's a couple of ways for survivors themselves to find support. They can be their own advocate, right? In the medical arena, talking to your doctor about what is needed. It's important to find your tribe, thinking about who can provide each of those kinds of things that you need. As I mentioned before, not everyone will be able to provide the exact same thing. Thinking about, you know, yes, you're going through treatment, but how can I still sort of maintain a sense of self? Is it getting my nails done? Is it getting a massage? Because when we look good, we do feel good. The other thing is asking for what you need, right? So sometimes, you know, people don't really know what you need. Is it, do you want a phone call? Do you want somebody to just drop a meal off at your door without you having to going out, interact with them? So that needs to be clearly communicated to. also when help is offered, especially if it's the right kind of help, accept it. Because a lot of times survivors say, oh, I feel like I'm putting too much burden on people. People do want to help. So it's okay to accept that help. And also it's important to speak up when that support or help is not helpful to you. That's not what you need. And then really thinking about how we can be kind to ourselves in this journey. So those are the things that survivors can do for themselves. But what all of us can do when we think about being our sister's keepers is, one, listening compassionately to what survivors need and to their journey. So sometimes people just want to talk about, it sucked today. It really sucked. They don't want, the cheery, oh, it's going to be better. It's going to be great. People just want to be listened to. So we all can listen to someone compassionately. We can offer support. What can I do for you? What might be most helpful for you? And helping the other person to really tap into the thing that brings them joy, especially if it's someone that you maybe used to go to the movies together with. Is that something you want to do? But also, I think the other thing is really respecting people's boundaries when it comes to what their needs, especially the cancer survivor. And I would urge us to not forget to check on our strong friends, the people we know who are going through, even though they did not reach out to us, it's our job to really reach out to them. So I think I have had a few minutes to present, so I thank you for your time. And if there are questions, I'm happy to take those.
Yes, Dr. Allaku, thank you so much. And we do have some questions. One of the questions from a caller, it says, what do I do when someone keeps pushing me away? Is this normal?
So if I understand you correctly, if the survivor keeps pushing you away, right? Is that if they keep pushing? I think you accept it. What you might want to say is that I see that, you may not be ready for any interaction or a call or whatever it is that you were doing, but I'm here for you. So whenever you're ready, let me know. Please reach out to me. So really accepting the boundary that person's created, but also still saying that I'm here if that's what your intent is. If you're really intent on providing support and helping someone else, saying, I understand that this may not be the right time for you, but please know I'm here for you in any capacity that I can be of service. Right?
Okay, great. Thank you so much for that. We have another one that says, what are some things I can do to show support to someone diagnosed with breast cancer?
There are lots of things, but survivors' needs vary, right? So for some people, some women, they may need help with their children and childcare. They may need house services and cleaning. Some people may just need a phone call. So I think it's important to ask that person, what might be most helpful to you now that I can provide? Is it just for you to call and, after your treatment and talk about that? Like, what do you need? But it's finding out from them what they need. I think it's important.
Okay, I have another one from a caller. She says, how can I support my friend who's going through breast cancer, but concerned that no man would want her?
Yeah, I think women, in anything, by being a friend, I would say, first of all, I think first and foremost, it's helping that friend and getting through the cancer, right? You can't predict what's going to happen in the future. You are who you are. Someone would want you because, whether you have cancer or not, whether it's a partner or spouse potential, people love you for who you are. Cancer isn't something that you have, and it's the scarlet letter that now you're marked and no one is going to love you or have you. So I think that's probably someone just freaking out, really. And probably it sounds like that person over time may probably think about talking to a therapist about their own feelings. But I think it's just reassuring your friend that they're okay as they are, right?
Okay, well, great. Well, thank you so much. We really appreciate that. We look forward to seeing some of your great work and being a part of the upcoming events that you're going to be hosting. And we look forward to seeing you again. And again, thank you so much, Dr. Allaku, for being a part of the
Yeah.
CTC.
Thank you.
Well, that kind of concludes our symposium for today. And we want to thank everyone for listening in, tuning in, sending messages. Again, we have had an awesome week this week. We started off our CTC this year, even though it was a little bit different, but we started it off with a week-long of breast educational seminars. So we are closing it out today with the symposium. We thank you once again, and if you have any questions or concern, please contact us here at Parkland. Again, thank you so much.